Today, my talk is mainly to tell you about what am I going to do with the routine data stream. Yeah, there is an overall aim for this routine data work stream. And one of the first things we want to understand is what is the local variations. And we also want to analyze the data and to make it more clear and how we can better understand patient and the carer's experience. And through the natural experimental design to understand about what is the effectiveness of different kind of service provisions and all sorts of different kind of policy level. And initially we were going to work with this stream with a sort of a main data source from one single source, for example, the death registry data. And eventually we will roll to do the data linkage and use more wide range of national level data. So Irene and I are leading on this stream, and our time frame for this work stream is the first 2 years. That is what we are talking about, the current, what we are planning to. So this is to fit into the CLAHRC, then we have to, we focus on the South London area. And current status is we are now doing the advertising our post, and we are hoping to get good statistician in to work on the projects we plan for. And in the same time, we are also applying for data access approval and also the ethical approval. Because I think our working stream is mainly based on the anonymized data, but we need to clarify with when we work on this new project, do we need any kind of new approval? But it generally should be quite low kind of criteria for us to get through. So the project we are going to work on is geographical accessibility to palliative care and end-of-life care facilities and place of death. What is their relationship in South London area? So this is a first analysis. We have just finished with NIHR, but I'm still doing the final report revision. And this is the first, the major result we get from our first publications for this project. And we look at the national level of place of death and how that varied across different regions. And we did see some effects of national end-of-life care strategy when the end-of-life care strategy started, and we did see some effects on the place of death. So the background for this project, geographic accessibility project, is mainly from what we observed and the wide variations in place of death across regions and in terms of place of hospital deaths and home deaths, and in terms of a lot of maybe different factors that contributed together and to make this kind of pictures. And the geographic accessibility to its relationship to health outcome and health utilizations has been well recognized in the other area. But in this end-of-life care and the palliative care area is still, there is evidence, particularly in the context of the UK and also in the South London area. And in the same time, we also can see a lot of variations in the service and service provision, service structures across different regions. So that's why we set up this study to help us to understand this better. So our basic research questions is, for whatever variations we observed in place of death, if we take into account of all other factors, because as you can expect it, and across different regions, there are quite a lot of other factors, demographics and the clinical difference, so social factor difference, and how if we take into account of all those differences and to what level the place of death is still varied by region. And we also want to understand to what extent the palliative care and end-of-life care facilities differ by regions. And after we understand these two questions better, then what we want to know is what is the role of geographic accessibility to these facilities in place of death. So there are quite clear implications for the output from this project. They can help us to better understand the role of geographic accessibilities in place of death. And it can also help us to optimize our existing resources. And also, if we want to plan some new services, new resources, we can inform the service planning and the resource allocation. So we are going to use the data resources from mainly from the cancer registry data that is it's cancer death registry data that is individual level data. So we will got basic demographic and cause of death information from there, and link it to the aggregate level data. So we are now planning to have 3 types. We are quite clear about it, about facilities related variables and the workforce related variables and the service related variables. And this is for the other variables and also for what I showed in here in these slides. And I pretty much want to hear your views and your thoughts about how we can get more relevant data, relevant variables in. So there are several other ongoing routine data-based work within I am associated with. And one of the project is the Guide Care project. This is NIHR funded and it's recently finished. And another one is Guide Care Children, and it sort of look at place of death, the variations in place of death, and at the national level, but focus on the children and the young people population. And the third one is we are using the general practice research database to look at prescribing patterns across the national.